everyone. Thank you for watching our group's debate presentation. I am Josie Nguyen from Southern California. I am the introducer of the group. Our debate is going to follow informal format, which we think is the appropriate and effective way to demonstrate our points. Our group members are myself. I will be the one conducting the introduction and conclusion for the group, as well as the illustration for the presentation. Brooke will be the summarizer, researcher, and tutor for the medical model. Candy will be the summarizer, researcher, and tutor for the sensory integration therapy. Laura will be the summarizer, researcher, and tutor for applied behavior analysis, ABA. After the conclusion, we will have Q&A at the end of our debate today. Our topic of the debate is alternative models to address quality of care for children with the autism spectrum disorder. Three popular theoretical perspectives that we are going to debate on regarding intervention for individuals with autism are the medical model, sensory integration therapy, and applied behavior analysis. As indicated in the name itself, the medical model mainly focuses on medical procedures where the licensed physician prescribes medication in order to reduce the impact of autism. Sensory integration therapy assesses the sensory need of the individuals with autism and provide treatments based on their needs. And applied behavior is the process of systematically applying intervention based upon the principles of learning theory to improve socially significant behavior. During our debate, we will examine many factors among the three models. These factors include the influence of political, economic, and societal factors, with research and findings about the impact of parents' choice, professional autonomy, and advocacy organizations, as well as ethical dilemmas. Let's hear what Brooke has to say about medical model.
The summary of the medical model of disability came about in the 19th century and was centered about the belief that a disability is a product of biology. This product then deviates an individual from normal functioning of daily living in which that individual cannot participate in society. This model believes an individual's impairment influences them in a negative manner in which they require a need for medical treatment, financial help, psychological, and social support. The medical model focuses on the individual and their disability as the problem rather than the individual and their needs. Physicians play the role of diagnosing a child regarding the disabilities and thus labeling them as disabled. Many physicians, through a biological standpoint, believe the proper way to handle a disability or long-term mental illness is through medication to fix the problem or abnormal condition. A common goal is to achieve normality. There is also parents with children with disability who are for and those who are against the medical model of disability. No matter one's position towards the model, one thing is certain, that the medical model reached people from different professions and backgrounds to start discussing the matter of disability and how treatment affects the individual, their families, and our society.
So sensory integration therapy is often referred to as SIT. And I will talk about who developed it and who uses it. We will go over information obtained from current studies from journals that are scholarly peer-reviewed journal articles to show research for and research against SIT or sensory integration therapy. And then also go over the impact for parent choice, professional autonomy, and advocacy. And I will also discuss some of the ethical dilemmas with sensory integration therapy. And then we will need the next slide. There we go. So sensory integration is the process through which we sense the world around us, and we use the sensory organs to receive this information. And on a higher level, we organize that so that we can understand our surroundings and respond to it appropriately. So like our vision, our hearing, our touch. Sensory integration is also where we perceive, organize, and modulate and interpret the sensory information. And sensory integration is the breakdown in the sensory process that can affect our behavior, communication, our functioning, and how we participate in our daily living. Sensory integration was developed by Dr. Ayers. She was an occupational therapist, and this was back in the 70s. She was the first researcher from the different therapy fields to define and work with sensory integration therapy. She defined the impact of sensory processing on learning, emotions, and behaviors. She designed and standardized assessments that provide comprehensive understanding of sensory integration function and dysfunction. And she also created a set of intervention principles to address sensory integration deficits for improved functioning and participation of clients. And this is just a little figure to help explain the signs of sensory and where you could be having those problems. So maybe somebody with oral sensation, they chew on things a lot, so they might need a chewy or chewlery kind of thing to help with that, different things like that. And so as I talked about before, the normal senses that we all think of are our 5 senses. So our touch, smell, vision, hearing, tasting. The other 3 are kind of unknown. So the vestibular and then the internal organs are interoception, and then the proprioceptive receptors. So just to kind of talk about those more, since we all know about our 5 senses that we all learn in preschool, the vestibular receptors are responsible for detecting changes in position in space, balance, and movement. And so sometimes that's where they'll do a weighted vest or a compression vest, just to kind of help the child feel where they are. The proprioceptive receptors provide information about body awareness, position, and posture. Interoception involves the internal regulation response in our bodies, such as hunger, thirst, our blood pressure, and even when we need to go to the restroom.
Okay, so ABA, also known as Applied Behavior Analysis, it is an evidence-based therapy that is based on behavior and learning. And it helps us understand exactly why behavior occurs, how the environment plays a role in the behavior, and how an individual learns. So some goals of ABA include decreasing problem behaviors that interfere with learning, increasing helpful behaviors such as language, communication, social skills, attention, self-care skills, and academics, just to name a few. It also assists an individual to live independently. ABA therapy or ABA programming is formed based on the needs of a client. So it can be provided in a variety of locations. That includes like the home, in-center, community, and school settings. It can use one-to-one teaching as well as group instruction. ABA therapy is provided by highly trained professionals. So this includes RBTs, which are registered behavior technicians, BCABAs, which are board certified assistant behavior analysts, and BCBAs, which are board certified behavior analysts. So again, just to reiterate, ABA is an evidence-based intervention, and it's proven to have positive results through scientific tests of effectiveness, quality, and usefulness.
So what are the research findings regarding each model?
So for the medical model, research behind the medical model shows how the model categorizes individuals with disabilities as being disabled and non-disabled by focusing on the physical and biological aspects of a specific condition. It separates those with abnormalities from the deemed normal within society. Physicians then become the gatekeepers for diagnosing a disability and its consequences. Physicians use problem solving through medical history, physical exams, and diagnostic tests to determine the deficit or dysfunction in a patient for identification and treatment of an illness. The treatment of an illness regarding a disability is typically through medication. The medical model did bring with it the ability to qualify for medical treatment, financial help, psychological and social support. This support, however, is only available to those who are deemed disabled through various screenings from the government, insurance programs, military pensions, and the courts. That means that some individuals who had a disability but were regarded as able in terms of able to work were unqualified to receive any support. Many models that are used today have stemmed from the medical model's approach of disability, such as the social model and ABA. ABA and the medical model share a common belief and goal of eliminating the symptoms of disorders such as ASD. ASD is treated similarly to medical disabilities by physicians because, according to physicians, it is the medical problem that interferes with normal functioning and thus needs to be normalized.
So there's lots of research happening with sensory integration. And so there's several studies that have found positive results with sensory integration. And so these studies that I'm presenting right now are for sensory integration. And so this study by Pfeiffer, Koenig, Keenly, Shepard, and Henderson in 2011 found that using SI interventions in children with ASD did support their finding that it was beneficial. The results were identified significant progress toward individualized goals and a decrease in autistic mannerisms after they received the sensory integration interventions. The results of this study also suggest implementing interventions that are generalized to home and community settings using tools that allow individualized sensitive measurements in future studies and complete future studies with a larger sample. And so that's why a lot of the studies for sensory integration, the sample size have been small. It's also been, they're not all researching the same behaviors. So there is further research that needs to be done. And so the research against sensory integration, one study states, Shaw, he states that sensory integration does not work. And he states that there's no evidence that SI therapy is or has ever been an effective treatment for children with learning disabilities, autism, or any other disability, developmental disability. There are plenty of quality outcome studies. At the time Shaw was looking over, there were 41 studies that were done, and there's no studies that use a quality research design. So which means there's no random assignment of the subjects, matching control groups, consideration of the effects of maturation, things like that, that finds that sensory integration therapy to be effective in reducing any problem behaviors or increasing any desired behaviors. However, for a procedure with no evidence of efficacy to be used on the public with claims of success, to charge money for these services and to train practitioners in this model borders on ethical behaviors, according to Shaw. So just a summary of these results. There are many studies that exist that suggest that sensory integration works. Studies also exist that it does not work. An appropriate scientific conclusion is that the effectiveness of occupational therapy using a sensory-based approach is neither proven nor unproven.
Okay, so there is nearly 40 or more years of empirical evidence for ABA therapy. So to start off, there is a positive humanistic influence on ABA therapy. So the aim of a humanistic therapy is to help improve one's self-image. And it can be difficult to record, but you can see it through the progress that can be made through ABA. Research from Bailey and Birch and Fryman, they reported that individuals who receive ABA therapy actually gain improved quality of life, productivity, and nearly extinguishing all potential life-threatening behaviors. Lovis's research can also back this up. He conducted an experiment to implement 40 hours of behavior therapy a week with his participants, which actually resulted in improvements in IQ, social development, and the participants were mainstreamed. One thing that should be considered from this research is the intensity of weekly hours. I like to refer to this visual, this table. It describes the beginning of ABA intervention versus after receiving ABA for 10 months via the GARS scoring. So GARS is short for Gilliam Autism Rating Scale, and it helps identify autism in individuals, and it estimates its severity. So the higher the score, the more severe the autism the individual has. So this table, it specifically reports that after receiving 10 months of ABA therapy, GARS scoring has decreased by 25 points. So politics have an essential role in ABA therapy. The Applied Behavior Analysis Education website actually reports that in nearly all 50 states, excluding Idaho, there have been insurance laws that have been passed to ensure the governing of ABA treatment for those with autism. And through these laws, services are fully accessible to families due to ABA being deemed as medically necessary form of therapy. Now, insurance laws do differ between each state, but overall, within the states, they each have an age restriction, coverage, and visitation limits. There's a social influence that plays an important role in ABA therapy. Wilson and Matthew reported that social validity of treatments can help determine the social importance and acceptability of interventions. And they concluded that using the opinions of society can help researchers be a little more receptive to consumers or communities that are actually directly affected by ABA therapy. However, it should always be remembered that the behavior analyst should use the most effective treatment in the least intrusive way. Now, from an economic standpoint, caregivers of children who have ASD do face an economic burden due to the high costs that are associated with ABA therapy. McPhillamy and Dillenberger reported that families had to sell their homes, remortgage their homes, or even take out a bank loan in order to cover the therapy. Sadeh, Marcus, and Mendel concluded that there should be a universal healthcare system and an improved workplace policies should be made so that it recognizes the full impact of autism.
So what is the impact of parent choice, professional autonomy, and advocacy organizations for each model?
Okay, for the medical model, as previously stated, the medical model labels individuals with disability as the problem along with their disability. This does not settle well for many parents who have children with disabilities. Disability is, for most of them, understood to be caused by prejudice, oppression, and the denial of agency and autonomy. Mothers want to protect their children from discrimination that they fear for their child in the future. In one study, parents who have a child with disability were given the opportunity to share what they believe disability is defined as, and many parents' answers reflected the medical model in terms of how society views the disability of their child and sets limitations because of their disability. Limiting participation, requiring help, support, and assistance, and deviance from the norm are a few of the categories in which these parents answers reflected their child's disability. These answers focused on direct consequences of their child's impairment. Other parents regarded the medical model and the professionals who diagnose and treat their child with a diagnosis as having written off their child because of their disability, not giving them the proper intervention and opportunities to overcome their diagnosis. Physicians and other clinicians are the gatekeepers of disability status and the primary experts on disability and its consequences. The role of such experts is to determine the proper mix of cure, rehabilitation, and support appropriate to a person's impairment. One of the many health professionals, psychiatrists rather than psychologists, have adopted the medical model and have mainly used drugs to treat mental illness such as schizophrenia, depression, and OCD. And this little graph just kind of shows how the impairment is the problem in the disability.
So in the impact of parent choice in SIT is that it's very popular among parents, especially children that have autism, because of the ease. They're able to learn these things and do them at home from their occupational therapist that they work with. And then SIT therapy also uses play activities in ways designed to change how the brain reacts to touch, sound, sight, and movement. And so then the impact of the professional autonomy is that pediatricians should recognize and communicate to families about the limited data on the use of sensory-based therapies for childhood developmental and behavioral problems. And then the advocacy organizations, there's several organizations that do provide and implement SIT therapies, and one is called SIGN, or the Sensory Integration Global Network, STAR Institute for SPD, Sensory Processing Disorder, and then also Autism Speaks. They do funding for research on sensory integration. And then this is just a chart to show parent report of comparison between ABA, SIT, sensory integration, and then a vitamin B6 and magnesium prescription. And so parents who saw positive improvements in their child, SIT had the highest. They had 80% parent approval. Neutral, it was 13%, and negative was 6.7%, where they didn't see any results. And that was from the sensory integration. And that was the highest results when comparing the three.
Okay, so in regards to parent impact with ABA therapy, McPhillamy and Dillenberger's research has shown that impact of parents choosing ABA therapy has actually provided them with positive dramatic changes, especially in their ability to manage family outings. They have lower stress levels, a better quality of life, and a positive outlook on their child's future. Families typically stated that they were more able of doing things outside of the home thanks to their exposure and learning how to deal with difficult problem behaviors via ABA therapy. So I want to refer to this table. It shows the parental effectiveness of ABA therapy on specific target behaviors such as social skills, communication, gross and fine motor skills, and quality of life. So the majority of target behaviors fall under level 5 and 4, which are the two highest scores for showing very effective progress. In regards to professional autonomy, it'll be discussed later on in the debate when I review ethical concerns. Now, advocacy organizations, they have a major impact on ABA therapy. Autism Speaks specifically, they seek to promote the independence throughout the lifespan of an individual with autism, and they provide support and advocacy to the individual and to their families. They aim to increase understanding and acceptance worldwide. They have actually increased autism awareness by over 50%. They also play a role as a catalyst for research, and they do this by pushing for increased federal funding that can be applied to autism research. And they also aid in increasing the timely manner of early childhood screening.
So what are the ethical dilemmas of the medical model, the sensory integration therapy, and ABA model?
So as far as the medical model and ethical dilemmas, individuals who are classified as having a disability by the physicians are labeled as disabled for the remainder of their lives. This puts a wrench in their quality of life within society. Based on the medical model and many programs for work through different screenings and tests, if someone who is disabled and they pass tests as someone who can work, then they aren't considered disabled as being that they can no longer benefit from financial help, psychological and social support in different programs. And so this limits their ability to thrive within society and function as a normal member. The medical model's way of treating illness and abnormality through medication doesn't give the individual the quality of life they're encouraged to have via other interventions and treatments. Other treatments try to integrate an individual with a disability into society to function as a member of the society rather than just treating the disability with medication to normalize them.
So some ethical concerns with sensory integration, since we don't know if the approach really, if it works and how it works with every kid who has sensory issues. And this is especially true since sensory integration is really neither proven or unproven. In sensory integration world, there are too many assumptions about cause and effect. The explanations seem logical, but they are not based in careful study about whether that logic is actually true, and a lack of research that clarifies how and how much they work to improve a child's functioning. So we need more studies in that area. And studies are also poorly constructed. So they have small sample sizes, and and then also studies that show that treatment actually didn't work.
So for ABA model, Dr. Simmons-Reed explained that there are 5 main ethical concerns in ABA relating to the BACB compliance codes. So the first one is the right to effective treatment. Basically that states that you do no harm and you benefit others. Second is the responsibility to recommend scientifically supported and most effective treatments. In this case, one or the behavior analyst should always advocate for respecting autonomy. We should always promote the client's independence and self-sufficiency. Third is the behavior analyst's assessments are sufficient to provide appropriate substantiation for their findings. So a behavior analyst should never start an intervention without running assessments or ever seeing a child. So you always want to make sure that decisions are always based on data. Fourth is the multiple relationships and conflicts of interests. This may include interactions with the child or families that may go beyond the role that of a therapist. Last is the functional assessment. So concerns associated with this includes like lack of resources, professional judgment may be getting in the way, and an overemphasis on descriptive assessments versus experimental assessments.
So let's sum up where we stand in this debate. Autism is a lifelong disorder and it's found worldwide in families of all racial, ethnic, and social backgrounds. Based on the Centers of Disease Control and Prevention, the prevalence of autism is now 1 to 59 children in the US. They report that boys are 4 times more than girls in having autism across racial groups, ethnicity, and socioeconomic. Nowadays, the cure of autism is still unknown. The work in finding effective treatments for autism is still in progress. The three popular interventions we are debating on today are medical model, sensory integration therapy, and applied behavior analysis. We have analyzed these three models based on different factors, and we came to the conclusion that applied behavior analysis is the best model among the three models. Next, we are going to answer related topic questions. First question is, do you have any personal experience related to this topic that you would like to share?
And I'm going to talk about that. I have a daughter who is 19. And when she was little, we did some of the sensory integration therapies, and one was a music therapy. And she had to have special earphones and listen to music that had like different layers. I'm not quite sure how to explain it. And her other therapy was horse therapy, and she absolutely loved that. I kind of felt at the time I was young and I really didn't know research on these things, but out of all the other different kind of things that you hear about, like the bleaching or the different diets and things, these therapies were things that I figured that they wouldn't hurt her in any way, and I only felt like that they could benefit her. I didn't see any negatives to them, and so she loved the horse therapy. The music therapy was not one of her favorites, but she did it. So that's my experience with sensory integration therapies.
Thank you for sharing that experience with us. Next question, how do you respond to a parent who decides to quit ABA therapy in lieu of alternative treatments?
So I'll answer that one. First off, I would probably inquire as to what the family were uncomfortable with within the therapy, or where they felt like their child wasn't making progress. I would also gather all of the data and the graphs to share as like a visual support to show them of what their child has progressed in. But I would share all of this without the expectation of this information changing their minds. From a professional standpoint, I would just have to respect the decision of the parents and be there as support with any information that they may request regarding declining further services.
Thank you, Laura. Next, how do you approach a parent when you realize that an alternative therapy may be impeding progress in therapy? For example, a med change has increased aggressive behavior.
So for this, it's never easy to approach a parent with anything negative that involves their child, but I think it's our ethical duty to do so in regards to the physical and mental well-being of a child. And a simple answer is just to communicate about it, keeping an open line of communication between parents and the professionals and just the whole team that's involved with the child's treatment, and key to successful intervention for that child. If the meds or anything has increased an aggressive behavior, then just really notifying the parents of this and the effects in regards to the intervention and treatment is the best decision to make for this.
Thank you. I think the last question is similar to the previous question. Licensed occupational therapist implements a sensory diet into their sessions to address sensory needs. If the OT is requesting that a sensory diet be implemented across all settings and into your sessions, how do you respond to another professional requesting the use of your sessions? So I think it's the same concept when, like earlier questions, when a parent approach and believe an alternative therapy may be the one. So these questions that we would approach the professionals as we would approach the parents, like we will listen to them to see where they stand from, what are their points of views, and we will use professional judgment and make a best decision based on the client's needs. Do you have anything to add? to this?
I think also as professionals, we want to work together with that other professional and understand their point of view also. And then just kind of talk that out a little bit also with the parents, like you said, Josie.
Yes, I agree with that. I think we're going to conclude our debate. And thank you so much for watching our presentation.